Big welcome to everyone across Australia and New Zealand who have joined us today for our webinar on audits, which is one of those topics that I think everyone can associate and relate with because you've probably all been engaged in it at some stage during your career. So we've decided to run this audit today, this webinar today. And we've invited three excellent panel members who are hopefully going to be able to answer all your questions. So it's a great opportunity for you to raise your hand and write us a question via the chat forum. And Peter Kench is going to keep a lookout for questions. And we encourage you to interact with us and use the panel and ask away all the questions you have on audits. Because audits can be seen as a sort of a softer option into research and can provide excellent opportunities for novices in research to gain confidence and some experience. So before we start, can I have a very brief introduction by each of the panels, please? Let's start with Peter. Just introduce yourself so we know which face to put to you.
Yeah, hi everyone. Thanks for the invitation. Brilliant to be able to join you, and a great theme. Yeah, so I'm Peter Coombs from Monash Health. I sort of look after the ultrasound service at Monash, which is reasonably large across 5 hospitals, and there's about 60 sonographers.
And lots of audits going on.
It's part of our fabric. I get really excited about it. So yeah, no, this is good. Yeah,
fantastic. So Peter has got incredible experience we are very lucky to have him on the panel today. Okay, Rhonda, you're next on my list.
Thank you. Hi, so I'm Rhonda Joy Sweeney, the University of Auckland, obviously New Zealand. So welcome to some New Zealand names that I recognise here. That's really exciting. So I'm going to confess to being rather a novice researcher in this space, and have only just started creating a audit research for our honours program. And it was quite a learning curve going into the ethics application for that, and to backtrack and try to find out where auditing belongs within medical imaging and where we can get some really, really useful resources. So thank you.
Okay, and Karen, thank you.
Hi all, welcome. I'm Karen Finlay. I'm Senior Lecturer in Medical Imaging at Central Queensland University. I've got experience of clinical audit, mostly in radiography reporting, image interpretation, and some process audits. So the 4-hour wait for emergency department. And I've taught basic principles of clinical audit to undergraduate student radiographers.
Okay, fabulous. Thank you. We've got your bios up on our e-blast, so you can have a look and contact any of us if you have further questions after the webinar. So we wanted to just start off asking Karen to maybe define what an audit is so that we're all on the same page. So could you start off with an introduction, Karen?
Absolutely. And I'm going to take this from principles of best practice in clinical audit from the National Institute of Clinical Excellence. I'm not making it up. Clinical audit is a quality improvement. Bear with me, my video's gone off. Try that.
We see you now.
Clinical audit is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria. Where indicated, changes are implemented and further monitoring is used to confirm improvement in healthcare delivery. So it's a cyclical process. You know what your standards are, and of course standards may change, so you've got to make sure that you're up to date with what the standards are. Make sure that what you're doing is actually answering the question that you're asking. Gather the data, assess the data, compare it against those standards. Should intervention be required, design that intervention, and then re-audit again to make sure that that intervention has actually produced the result that you're wanting.
Yes, and that is that's the difference with just a quality assurance project, isn't it? that you've got benchmark standards to compare it against?
Sometimes audit can be used to create benchmarks if there are no standards currently available. And you've got the pyramid of what standards are you going to compare yourself against, whether it's international, national, whether it's legislated, whether it's a guideline. And occasionally there is nothing there, in which case benchmarking is needed. But most audit you are comparing against a published standard.
Yeah, so you are aiming to compare your own practice and the performance of your own practice against those standards. They could be national or international, or even local.
Yeah, and it's either your standard or your process. So I've done them in the past where I've been looking at a whole process and I've just audited one section of a big process. So it could be personal or it could be quite a big multi-agency audit.
Yeah. So I wanted to move on to Peter here, because I was very lucky to listen to him. Was it 2 or 3 years ago? You presented an audit at a national conference. Would you like to tell us about that study, Peter, and why you did it and how it came about? Yes,
sure. So it's fair to say, maybe just to dwell on the definition for a moment, certainly at Monash, we see a blurred line between quality assurance and clinical audit. So the two sort of run together in so many ways. And so this particular study it's actually on the reading list that Peter's provided. It's a pediatric renal ultrasound study where we measured renal length and it began with really a quality project out of the department where the published standard for renal length in pediatrics was very old and really poorly put together. We weren't happy with it. So we began as a quality project really to see how our measurements compared to the current standard in terms. So what are the normal measurements for a pediatric kidney? And so we ran a very small quality process and we thought there were outliers. And so what we did, we engaged some undergraduate students from Monash University who then, so again in the process, we needed to identify some normal kidneys to be measured. And so we found a low risk group within our own population. We identified them, we engaged these Monash University undergraduate students, and we compiled the measurements over an extended period of time. We observed these retrospectively, and they eventually were published. Yeah, so it sort of evolved. It didn't actually just happen. We didn't wake up one day and say, we need to publish a paper. And so this paper has been published in Pediatric Radiology. It's probably the best paper that's been published on normal pediatric measurements, but it evolved out of a quality project within the department itself.
Yeah, and that is such a beautiful example to show that a small project like this can develop into a publishable paper that is, so useful for other sites to have and compare against. Rhonda, you are starting off with the project. Would you like to explain the project you're working on?
So we were actually approached from a clinical site, 2 hospitals within what we call a district health board here in New Zealand. And they wanted to compare the image reject rates between the 2 hospitals. They perceived some differences. So we've taken that on as an honours project. And I guess one of the first things is to confirm that the project or an audit has not been undertaken before. So obviously there's a lot of published reports on image reject rates, but there was none for New Zealand, and specifically within an environment where hospitals were quite close and they've maybe had similar staff and sometimes the same staff, and they're both teaching departments. So the beginnings of that was also to identify where can I get information about audits. And without a doubt, the ethics publications, both locally for the university, for the District Health Board, and obviously for health in New Zealand, all you'll find have sections on clinical audit. And if I can just share a couple of textbooks that we do have, sometimes we forget what is published for our profession. So They're just books that I have, and I don't know if you can see that. Oh no, you're not going to be able to see it. So it's Quality Management in the Imaging Sciences by Jeffrey Papps. So that had an excellent section. And the other one is Medical Imaging and Radiotherapy Research. There's a 2020 version out by Arthur Ramlall. It's absolutely excellent. There's a whole chapter on audits. So that was a lovely place to start, and then to go through the process of, if it's secondary data we're using, how do we then approach the ethics application? So I can fill more on that later, or now, depends when you, I mean, that's best to talk about that.
Yeah, so ethics is one of those issues around QA and audits. If anyone has any experience or would like to comment, please feel free to chat. Karen, what is the situation with ethics? Under what circumstances do we need to get approval from an ethics committee?
Now, I'm going to put my hand up right now and say I have never sought ethics approval for any audits I've done. And that's because they were purely internal. And they were never going to go for publication. If they're staying internal, you don't necessarily need it, depending on the particular ethics committee. But certainly if you're thinking about taking it outside the organisation, presenting, publishing, you will absolutely need ethics clearance.
Yeah.
Maybe I can talk to that.
Yes.
So we've had success in the last, we've had 2 projects get over the line in the last 6 weeks in terms of ethics. And certainly the state of play in Victoria at the moment, it's actually very easy to get low risk ethics for essentially quality assurance clinical audit projects. So the criteria are that it's retrospective data, generally no engagement with patients prospectively. And certainly the turnaround time for, so I'll talk about the project. So the project's looking at thyroid nodules, and what we're going to run these thyroid ultrasound images of thyroid nodules through some machine learning. And this will be retrospectively compared to fine needle aspiration. So it's retrospective the nodules have been obtained retrospectively. So there's no impact to patients, and the ethics took 4 days to turn around. Once it was submitted, our local Monash ethics just approved it as a quality project, and we've all moved on. The really wonderful part about getting ethics up front is it gives you confidence then if you want to take the process to publication ongoing. It's there, it exists. There's no confusion around it. So I'd encourage everyone who's involved in low risk projects to get used to the cycle of getting ethics approval. We've certainly had, as I said, 2 projects approved very quickly in the last 6 weeks.
So what are the main issues with the low risk ethics associated with audits? I know confidentiality and consent are usually the ones that are highlighted. So how do you deal with that?
Yes, certainly the consent isn't an issue for our ethics board for retrospective data. In terms of as long as patients aren't identifiable. In this particular thyroid nodule, there's a exclusion, so allowing people to have access to information. So at the moment, the only people that can collect this data and use this data are Monash Health employees. And it happens because we're engaging an external provider in terms of the machine learning. There's some complexity there. And so we may need to go back if we want to provide the data to this third party, even though it is de-identified. We will need to get a low risk ethics rather than a quality assurance project of ethics, if that makes sense.
Can I just add for New Zealand, I've taken some questions from our ethics application, because without a doubt, we're very strong in requiring ethics, even though it's low risk. And one of the first questions I think is to ask yourself is, who is the group that this information might benefit best? And I guess for most of us, it is going to be the patient, and improved health outcomes, even whether it's directly or indirectly. So a couple of the questions that we were faced with: how will the study contribute to new knowledge and or improve health outcomes? Describe any benefits the study may have for your study population. And initially I considered that there was no ethnic information. We wouldn't really be translating it backwards, but in New Zealand we do have a responsibility that involved in the development and maintenance of respectful relationships during research, that we engage in with MRRN in the decision making. And that's quite important. So we have quite a range of questions to think about that. And it was a challenge thinking this is secondary data. I realised later that I could actually retrieve ethnic data, but it wasn't important for this particular project. But it's to embody those questions to yourself and think, well, is this an opportunity to consider it? And it's actually a responsibility for us under the Treaty of Waitangi in New Zealand to put those considerations, even if it is what we would consider and is considered a low risk ethics application. So it does actually take you a step further into the thinking and then going, in that case, when the results are found, what groups and what methods should the information or could the information be disseminated? And that's important within our professional groups, because often audits are multidisciplinary as well, and the findings might be important to groups other than we originally thought of.
Yeah.
Yeah, I think I'd encourage everyone to apply for ethics in the first instance, Michal. There's some learnings in the process. I mean, what Rhonda's spoken about there is just one of the many learnings that come by going through the process. And it actually teaches the process as you go through that. And it becomes much easier the more you do it. So
it does. It forces you to really focus on the research question and your aims and the proposal, and you have to provide a bit of a literature review. So it does focus you very much and start you on that research journey, which is why we are doing this webinar, because we are trying to tell people that research skills can be attained by doing these audits. And getting an ethics application is a research skill that you can learn along the way. Are there any other research skills that we can pull out of running audits?
I like the
really good one there, Michal. The idea of getting the right questions, because it's very, very easy to have a very broad question and your data methods just don't really answer it. So, yeah, and you were saying, Peter, how your ethics application, you were under joy about how it narrows it down and you're thinking about it. And I think that's really important to make sure that you're asking the correct question.
I'm not too sure where I took this from. I've been doing a bit of copy and pasting before joining tonight. Obviously, as practitioners, annual practicing certificates require CPD, and I'm sure in Australia as well as New Zealand, the reflective practice is an important component. So if I can quote, the growing frequency of reflective practice means that research is already an element of practice, but already features in interactions between the researcher and participants. So running an audit is actually a form of reflective practice. And I don't want people to be frightened if they think, oh, I could just run some tests and look at some results, or this ethics conversation. There's people there to help, including us on the panel tonight, even within ethics committees, and other people will have gone through this process. And if not, it's seldom a solitary process. It's always great to have somebody alongside joining in and sharing their experience.
Yeah, that's one of the issues that I wanted to raise was mentorship and creating a team. And what are your suggestions or advice if somebody wanted to start an audit? How do they go about getting a mentor or build a little team to help them along the way?
we're all saying, oh, who's taking this one? I think it'd be nice if you're not, I think confidence is an issue when it comes to audit, because it can feel like a big scary monster. I think it can be really, really useful if someone in your team, in your workplace is doing some audits, just offering to help and getting in there and asking questions and helping out. And then perhaps putting your hand up later and saying, well, if you mentor me, I'll take the lead on it. And just build your confidence up in small steps and scaffold your skills.
So how do you manage workforce issues? I mean, a lot of people say audits is just an extra piece of work that we have to do as part of our work. And then people shy away. They don't want to get involved, but they don't see the benefits of running these audits. So how could we encourage people to participate?
Yes, so I think the first bit is to, again, dovetailing it with quality assurance. So maybe I might just talk for a couple of minutes about the way we use audits at Monash and the way they emanate from a quality program. So I've identified 5 ways that we use audits in our workplace, and they're part of the fabric of what we do. So you talk about the notion of how does an individual. So we don't ever talk about individual audits. For us, it's a team audit. There are team leaders who manage the audits, and then we're interested in them because of the results for the team. You're never auditing self. It's always us. And so the whole rhetoric about it needs to be about us and the team and about where we're heading. So we use them for 5 ways. And so the first is any area that has cognitive bias or interoperator variability. And so all of imaging is full of interoperator variability. And so things that impact patient care, again, they can be regularly audited. So we have regular audits of, again, thyroid nodules, of cervical measurements. There's a range of things we have regular audits for. The other is, the next is the individual quality issue. Someone says, we got that wrong. So rather than dealing with the error, you deal with it in an audit context. Let's review, from a quality process. And again, from that will emanate big research questions, audit questions. The third is the squeaky wheel. You guys always get this wrong. You guys always get this wrong. And rather than berating a team for always getting it wrong, by doing an audit, the response is often, actually 98% of the time, we get it right. And actually, it's a very strong way of sort of dealing with external criticism. And then the last 2 are really important. We have a complete program, which is an audit program of all scans that are done by physicians. So we have a full, and that is published, that is now published in 2 places. And then it's used also on the road to research. So there's this notion of team, and there's this notion of embedding it in your quality culture. And it then becomes just part of you, I think. You just need to take small steps, very small quality projects, small amounts of time, and things that are important.
And I think a recognition to some degree that what Peter says is absolutely right, and a recognition that an audit can lead to more training, more CPD. It can identify gaps in knowledge and skills, and it can identify, in radiography at least, equipment failures or equipment drift, so we can get equipment serviced. So it's not a blame game. I think that's important to recognise that audit is not a blame game. It's a tool to lift people up and lift processes up to a better level.
Yeah, even more than that, Karen, I think in our group, we put out these audits to the operations groups, to executive level, and there's a real pride in the audits. And so the team see this as really important in terms of who they are, and they see themselves as a team of excellent sonographers because of this audit culture that exists. So they're really proud of that work, and so it is a way of really growing a strong team.
I think it gives the staff an opportunity to identify where in-house training is perhaps required to be either updated or introduced, and then to go back to check that's been effective. And that again attests to that pride in one's work and taking ownership of one's imaging within a team or a department, and just seeing what's happening over. We're quite interested in our particular examples, what happens over the course of the 24 hours, why maybe the changes take place in terms of reject, but particularly between the two institutions is the major criteria we're going to be looking at. I hope you didn't hear a very noisy motorbike go past.
No, it's all right. I've got my dog jumping around.
It sounds like it's in the room, but it wasn't.
With audits is that once you identify a gap or something that you need to improve on, how do you go about then? This is the next step, and that can really nicely build into a research project. So how do you go about building the next step into the audit? Because the re-audit step is so crucial and so important to see that we have managed to improve on our practice. So how would you go about taking that next step?
So I think the first thing you need is an audit tool. So a document, just a resource that will guide everyone on how to perform an audit. Because it's fine for everyone who's online. Most people probably have some sense of how to go about this, but there's many who don't. So we have an audit tool online that someone can download. It's the simple steps, and it really is define clear objectives. Make sure your methodology is carefully documented. Make sure there is some literature sitting behind it. Making sure what the standards are. So we have this. It's very simple. It's no more than an A4 page. But it really directs people how to do that. And then there's some strong messages. The strong messages about the methodology being very clear, so that the person who is doing it next time can repeat the audit in exactly the same way as it was done previously. That the standards have been updated and they're very clear. So again, clear tools and sort of clear instruction.
I think what's at your site, you have that, but a lot of sites don't. A lot of smaller hospitals or private sites don't do that. So people are left more in limbo, which is a shame. And I'd like to encourage everyone who is listening to let us know what is stopping you from participating or carrying out an audit. We'd really love to find out. So please engage and ask questions while we have the panel here. So Rhonda and Karen, in New Zealand, do you have tools available? Are there any tools that people can find, or do they have to create their own in their own site?
It would depend. I think within the District Health Board, you'll probably find that there's actually processes that already exist. But without a doubt, all the ethics documents that I found I really had to review in terms of preparing it had a section on clinical audits. So already had that information. And once again, the book by Arthur Ramlaw has a flow chart. It's very simple to follow and have a look. And I guess that's the other benefit of should I do ethics, shouldn't I do ethics? By having an ethics application in there, you're usually for 3 years, but you might find the initial results or the initial process, you may not have needed that ethics, but you may wish to add something to it. So that ethics already being in place, then it can be amended. And I think that's the benefit of it, because you might find you want to go deeper or a bit more information that needs ethics. And it takes that next step. You don't have to go back and do it. It's there maybe an amendment. In terms of tools, I guess looking at the literature, thank you, Peter, and all the others that have already done an audit and published, I mean, it's a gift, isn't it? To take that information and see how can I apply that to my situation. Because if we're wanting to compare against international outcomes or outcomes outside of our own research, that's the literature that we will be using. So we don't have to follow it exactly, but it's going to help us make a comparison.
Yeah, that's right.
I think, I mean, Peter's clearly got a fantastic setup there at Monash with the that simple, almost algorithm sounds perfect. If you haven't got that, you're in a small site and you haven't got that, and the idea of this frightens you, might I suggest having a little read of Clinical Audit for Doctors and Health Professionals, because that actually does have why to do an audit, how to do an audit, how to get your question, and it's got some guidance on how to set up your audit tool. And it's got some guidance on what to do next if you feel you need to put an intervention in. So it is a nice, simple, easy to read guide for clinical audit.
Yeah, I think something like this would be really helpful to get people over that initial hurdle to do that. I mean, it's interesting because a lot of our students who have to do a research unit as part of their master's course, they end up doing audits. And they are usually amazed at how interesting it is and how much information and how much benefit those audits are to the whole site, and many do present and publish. So we do encourage you to get over that initial fear or anxiety about it and just have a go. And writing that low risk ethics is a really good starting point. But what about, do you need a team to run an audit? Or is that something that people can do sort of on their own? What are your thoughts? If somebody has an idea to compare performance in their setting for a particular area, how should they go about? Should they get a few people around them and work together, or should they try and do a small study on their own?
Yes, so maybe I'll lead. So I think it's almost essential to have someone around you. It's really essential to have a sounding board for your question. And that's where it begins. You have a question, and this is what we want to answer, and so you need one or two other people at least to bounce an idea off, and then we have this sort of constant dialogue within our workplace around the size of teams, and if it gets too big, the quality of data collection begins to taper off. If it gets too small, the burden of data collection becomes too onerous. And so so my suggestion would be that there's an identifiable leader, the person who's responsible for the lead. And then there's a team of generally 2 or 3 others who are involved in the data collection. But the communication about the audit happening and can be quite extensive in terms of a large group.
I think for those starting is to actually take time and talk to a lot of people. My experience, because I'm not clinically involved as much now, was I assumed the data we were going to get was directly off the PACS system, and I wasn't speaking to quite the right group of people. And it wasn't until I went somewhere else and they said, but we can get this information for you. How much do you want? And I realized the options. So by sharing that, and that simple little process was quite interesting, because suddenly there was a group of us, and I don't even know who they all were, grouped around the monitor going, oh, look. And of those that came to see what was happening said, oh, we didn't know you could find that information. So suddenly, and it may have changed the focus of what was looking for somebody to say, that would be really useful by now knowing I can find that information to look at something else. So that's the beauty of sharing the idea, whether that's the final team to go forward or not, is to share with others, because they might actually just ask a question we thought, I hadn't thought of adding that to this particular audit, but it would be valuable to do it at the same time.
I think the team is really useful to make sure that you're actually answering the audit question, because we have our own ideas and we think we know exactly what we're doing, but then someone said, but what about? And like Rhonda Joy said, oh, right. Maybe I'm not actually answering the question that I thought I was answering. So I think having a team around you is really useful.
Yeah. Well, what do you do if you can't get any volunteers to help you? What do you do then?
So yeah, and so almost universally the reason is time.
Yes.
Yeah. So there's this it's about the value of this versus my time, and that's it's a dilemma, because there isn't a culture of providing time within imaging. Imaging is it's an economic workhorse for the health industry, isn't it, really? And so time is money. It's an MRI which isn't working, or it's an ultrasound machine which is empty. And so I guess you just have to make it a priority. You do actually have to say to the workplace, this is culturally really important to us. But also in the reverse of that, as a manager, I obviously can't give out large, enormous slabs of time to people who are involved in the motor production. So people need to be collecting data efficiently, and the audits need to be well done. They need to be at times simple and not. So you don't want to be collecting data of 500 cases if for the sake of the clinical audit, 50 or 100 will be sufficient. And so.
And that is a really good point, Peter, because sample size always comes up. How many is enough? How far back do I go in my system?
Yeah, no, you're exactly right. And the dichotomy is around time. Yeah.
So what do you have any advice around sample size, Peter?
Oh, so it depends on the project and what you're trying to achieve. And so, you know, so we have a standard, prenatal birth is a big issue in obstetrics, and cervical measurement is the number one tool to detect the risk of prenatal birth, early birth. And so we have a regular audit, and it's 100 cases, and it's done very efficiently. It would only take someone, you know, two hours to do the data collection. They do the data collection, they report back. It's done every year, and it's just it sounds quality assurance, but for us it's a really important standard in terms of meeting quality benchmarks. So
these are 100 consecutive cases?
Correct. Yeah. No.
Okay.
Exactly.
Over a set time period. And when you come to publishing, did you ever get questions about your sample size?
So in terms of our publications, so I think in the list that I gave Peter, there's an audit there of training and credentialing people to look at the corpus callosum in the obstetrics. And again, that's relatively small numbers, and we didn't get questions about our sample size. So no, it is curious. And I think the pediatric renal is a really good example, which actually started as a very, very small project. But when we could see that it actually had publication potential, we expanded it dramatically. So again, it depends on where the data is going and what you're intending to do. Sometimes the smaller sample size will do if it's just for internal use. But if it's for publication, then you can expand it if it looks like it's going to be valuable.
And I think it goes back to your research question. If it's really focused, you really use a homogeneous group of patients and you define them really well. There may be older patients, 70 plus, or pediatric of a certain age and with certain conditions, then you narrow down that sample size and make it nice and clean, which will, you know, reduce the need to have lots and lots of samples. But that again goes back to what is your research question. But if any of you want to do audit and they don't know what to do, then ask the question. You know, just find somebody who has done it or contact someone at the university and ask for help, because these sorts of things are common issues that even experienced researchers are dealing with.
I want to pick up something you said before, Michal, and you're talking about how the students find the results of the audits interesting. And so there's a perception that this is dull. And there's a perception and there's a perception. That
wasn't how I meant to phrase it.
No, there is no, and there is a perception at the end of the day that it's that my story isn't worth telling.
Yes.
So I just reflect on the most recent Sonographers Association meeting, national meeting. There's hardly any audits that were presented there. And yet these are everyday stories about the way we are performing within our industry. And actually, I find nothing more interesting to hear a real life story from another service in terms of the way that they're performing, because it helps me then judge about how we should be performing. So I think any perception that it's dull and boring, they're actually very informing and really interesting.
Yeah. I would love to hear from any of our audience who have been very quiet this evening, if they have done an audit or if they've had any issues with it or if something that's gone really well. So we've only got a few minutes left. So if you've got any questions or you want to make some comments, please do them now. Otherwise, we will have to close without that opportunity. Karen, are you teaching audits as part of your role?
I have done.
And
the unit has changed slightly, but yes, I have done and had students do audits of various aspects of their personal practice.
And do they choose their own topics, or how do you run that?
Yeah, when I first started, I did have the idea that they could come up with their own topic, but that was a massive source of stress for the students.
Why?
And, no, tell me, what do you want me to audit? So I ended up giving them a selection, pick one. And I picked very simple ones because this is undergraduate work. So use of anatomical markers, exposure factors when doing mobile imaging, Things like that. And then some of them became a little bit more confident and said, well, can I audit my image interpretation skills for this? Yes, just narrow it down a little bit because your question's too broad. So I was spending a fair bit of time shepherding them into narrowing down the questions so that it didn't become a monster. They only had a limited amount of time in which to complete it. But the students that did complete it found it really, really useful. And because they were only auditing their own practice and nobody else's, there was no ethics really involved in that. But they said that it made them reflect even more on their own practice, and they developed action plans to improve themselves.
Peter, at Monash, does everyone get involved in audits, or is this a voluntary thing?
No, everyone gets involved. No, it's so for the leaders, there are 11 grade 4s, and it's part of their outcomes that they need to lead audits. They have teams, and they would automatically involve in their teams, and the trainees get caught up in the data collection, and it's really important they learn the process.
Yeah.
I have a couple of resources. Will I just drop them into the chat, do you think?
Yes, please, because we've had quite a good list of resources added already. So thank you, everybody.
These are actually physical files that you, so
okay.
So there's two there. One is just a template that we use, and the other is just a very short paper. And people might.
We could also, Peter, he says muted himself, but maybe we could also put them on our webpage, if that's okay with you, Peter. We've got
sure. If they're free of copyright, we can certainly put those up.
Yep. So we are sort of getting to the close of our webinar, and I encourage all of you to think about audits and contact us if you want help, because we're all here to help you and to make this happen. And it is, as we have, I think, tried to outline, it's actually really exciting to finish an audit and get the opportunity to present at a conference and even publish is a fantastic outcome for an audit. The conference I was at, Peter actually got the award for best oral presentation, and it was an audit. So it shows you that a good audit can actually win you awards as well. So we want to encourage you to get involved and not shy away from it. So we've got 1 more minute. If anyone has any comments or any questions, do you want to please put them up? Otherwise, we'll all go off and have dinner. Any more comments from anyone?
Maybe I'll just finish by saying start small. Start small. Don't be overwhelmed by this. And so start with a tiny question where you know you have the data. So the length of time that it takes for someone to do something, or something really small. And then when you see the outcome, it'll encourage you to do something slightly more sophisticated. It will evolve. And so start small. Don't treat it as a burden.
Not at all. No, thank you, Peter. That's a very good point. And again, if you're not sure, ask someone who's done it before, and get a team around you, because that's the best way to move forward. Or participate in an existing audit. Put your hand up and get involved. Rhonda and Karen, any final remarks?
Absolutely. From New Zealand's perspective, I'm very happy to take any messages and questions. Where do I start? And thank you very much, Peter. I've just been downloading the documents you've sent through. They're fabulous as well. But sometimes you can miss them in this avenue. So because of some of the peculiarities for New Zealand, I'm very happy to share the learning, and we learn together. There's very much, I'm not an expert, but it'd be interesting this time, maybe next year, what was the experience? But I'm certainly looking forward to it. I think it's, hey, it's great for CPD points. it confirms us as being reflective practitioners, and it must benefit both our profession, individual medical imaging technologists, and definitely, most usually the patient. And I think that's really important. So it's exciting. Thank you.
Thank you, Rhonda. Karen, any final comments?
Yeah, I agree with both what Rhonda, Joy and Peter have said. Start small, don't make it a source of stress. When you get that buzz of completing something, not only will it encourage you, it'll probably encourage those around you as well, and actually build up a culture of audit.
Yeah, thank you so much. Well, I wanted to thank all our panelists today, Peter, Rhonda, and Karen, for giving of their time. Thank you very much. We appreciate you have so much experience, especially Peter. So from the comments I see, I think a lot of people enjoyed the session, and hopefully we'll get lots of good QA and audits going. And please contact us if you have any questions or ideas. We're more than happy to help. So we'll wrap it up here, and we look forward to seeing you at our next webinar. So watch the space.